program because Dr. Nicol has to catch an early plane, so we will start with Dr. Nicol talking about the evidence for and pitfalls of transanal TME. And all the speakers in this session, please stick to the time limit, which is now 12 minutes. We have to short down this session a little bit for the sake of time. So please stick to 12 minutes, and then we will have a few minutes for questions as well. So Dr. Nicol, please.
Thank you very much. Good afternoon. I'll try and keep it as brief as I can. Thank you very much for inviting myself and the rest of the Worcester team who are here today. We're very privileged to come to this beautiful place to the meeting. This is Worcestershire. It's not often as sunny as it is here in Crete. This has happened to catch it on a sunny day. But I've been asked today to talk about transanal TME. It's something that we've brought into Worcester, and in specifically looking at sort of evidence and pitfalls, but I'll try and keep it fairly general if I can. Transanal TME has been a while in the evolution. Rectal cancer surgery has changed significantly since Ernest Miles started talking about looking at things bottom up back in 1908, and we're privileged to have Professor Heald here today, although slightly intimidating for the rest of the speakers, I think. But rectal cancer surgery we know has progressed massively, and there's been a lot of things that have come about bit by bit from different places that have taken us to where we are in rectal cancer surgery in terms of laparoscopic TME, robotics, and obviously what I'm talking about today, which is transanal techniques. So why are we talking about this? Well, we all know, many of us who are laparoscopic rectal cancer surgeons, that sometimes it's difficult to get a view down in the pelvis. There's a part that's very easy, and there's a part that gets gradually more difficult, and that's difficult whether you do it laparoscopic or open, sometimes even difficult if you do it robotically. The level of division is also sometimes difficult, and although we don't always admit it, there have always been situations where some of us as rectal surgeons will have been PRing a patient and trying to work out whether you're getting low enough, whether you're down as far as you think you are. Sometimes you're not as low as you expect you are. And there's obviously been technology has not really kept up laparoscopically with what surgeons are able to do. And we know that although there are stapling devices are progressing all the time, that stapling devices still have some limitations deep in the pelvis. And so various solutions have been looked at to this. And of course, we've heard about robotics, and there's a lot of fantastic things about robotics, but I work in the NHS and I work in a trust that's in debt, and I know a lot of you will be in a situation where you don't have a lot of money to throw around, and of course robotics is not a cheap option, and there are also some other limitations to it. And so transanal surgery, where's its place? So why transanal? Well, it's the difficult patient. And we all dread the patient that walks into the clinic who's a man, who's obese, he's got a big advanced tumour, he goes off and has his successful neoadjuvant treatment that we've been hearing a lot of useful stuff about today, and he's got a big bulky tumour, and you look at him in the clinic and you know you're going to have a difficult day in theatre. Stapling concerns we've talked about, but it's not just whether we feel the stapler is good enough. We've got evidence to say that we use more staple firings, whether we admit it or not, the lower we're going and in difficult male pelvises. And the more firings of that staple gun you use, the more likely you are to get an anastomotic leak. So there are reasons to believe that what we're doing is possibly not good enough. We've talked a lot, and Professor Quirk's been talking a lot about the importance of a complete specimen and about the importance of CRM positivity. There is evidence out there that we're still possibly not doing a good enough job with those tumours lower down, and the conversion rates are still relatively high for laparoscopic surgery. So 17% in colour 2 is quite high, and obviously there have been some concerns raised. I too am a believer in laparoscopic rectal cancer surgery, but concerns have been raised about whether we're doing a good enough job, and there is evidence to support that. I'm sure most people in the room are familiar with the technique, but I will just mention just the basic steps of it, just to make sure we all know what we're talking about. So a transanal technique can either mean synchronous surgery, the Cecil approach, as Antonio Lacey talks about, named after Cecil the lion. I've never really understood quite why. Or it can be transanal first, or it can be abdominal first. So there's a lot of different ways of doing it. And it usually involves luminal occlusion below the tumour with some kind of purse string, or it can be an intersphincteric approach. There's then a full thickness rectotomy and circumferential dissection of the TME from below, with, very importantly, identification of the landmarks. And that's important when we come into some of the pitfalls, which crosses over slightly with the talk we had earlier from Dr. Seltzer on anatomy. And then obviously the specimen can be extracted, sometimes transanally, although I would argue very much that that's not the primary aim of the technique. That's an added bonus if you could do it, but it's not something that necessarily has to be done to make it a transanal TME. And then the anastomosis can be done in whatever way you want to do it, but either hand-sewn, stapled, and there's going to be a lot of talk about anastomosis today. So the evidence for transanal TME, well, the beginning really, it's fairly recent really in its evolution. So the first sort of landmark papers were coming out 2010, 2011, up to 2013. And obviously Professor Heald writing an editorial, I think, probably brought the attention of a lot more people to the technique. And this is numbers of papers published each year with transanal TME or TATME as part of the topic, and you can see that the numbers have gone up significantly over the last few years, so there's obviously a lot of interest. So in terms of the current evidence, initially, as you'd expect, mainly case series. The case series have increased in numbers as times have gone on, as people have done more cases. And obviously, Sabatella and Matt Albert's group in Florida have published, as have Antonio Lacey's group. And the results, initially in case series, look pretty good. So from Florida, 20 cases over 3 years, quite a lot of obese patients, as you'd probably expect in the States, with a reasonable leak rate for this sort of level. I'm sure Professor Quirk would be interested in the completeness of the TME. Antonio Lacey has then published 140 and then later 186 cases with very good completeness rates and good morbidity rates. But these are experts, okay? These are people publishing case series. What about a meta-analysis? Well, there have been 2 or 3 now published. This is one of the bigger ones, which shows 3 case reports, 25 case series and 5 comparative studies, with really good conversion rates and good completeness of TME, really, considering some of the rates we see in other studies for laparoscopic or open surgery. And a good 30-day mortality. And this was lots and lots of different people doing different numbers. But these are all people who have published. So what about if you compare it to other ways of doing this? So what about if you compare it to open or to laparoscopic TME? And this study by Purdwood attempted to do that. And this is a comparative study. This isn't a randomized controlled trial. But the rates were good. So the conversion rates for transanal TME was 0%, so they didn't convert any patients. And their anastomotic leak rates, they would suggest, are less, and they also suggested there was a lower operative time, interestingly, which not everybody would believe, I suspect, and a lower blood loss. But there's a learning curve to the technique. And so other papers have looked at that. And this was another case series, really, 138 patients from a single centre. But they did suggest that things improved massively as they went up that learning curve. And we'll talk about some of the difficulties and why that might be in a moment. But they felt that there was an improvement once they got to around 40 patients. And you can see there they looked at their own results very honestly, and their leak rate dropped from 27% to 5%, and the major complication rate dropped significantly as well. But what about in the real world? What about everybody else doing it? So the Transanal TME International Registry, set up and run by Roll Holt and Marta Penner and many others, is now recruiting patients from all over the world, really. Initially they published the first data from this, certainly in the UK. Our guidelines pretty much say you have to put all patients into this registry, which has certainly helped with their ability to get people involved. But last year, they published the first 720 patients on that registry, and obviously this is surgeons, signing up to it and putting the data in. But through 23 countries, and this is surgeons like me or anybody else inputting data, and the completeness of the TME was pretty good, and the mortality was pretty good. Since then, just this year, it's just come out in the last couple of months, they've now published 1,500 patients, and this is just patients having anastomoses, and these are very low anastomoses, between 3 to 6 centimetres from the anal verge. They've now got more people involved, so you've got to remember, not everybody's doing huge numbers, but they had an anastomotic failure rate of 15%, which in an anastomosis at that level, you can say whether you think that's good or bad, but I think it's probably a very honest recognition of what's going on. Where are we in Little Worcester? You've probably never heard of Worcester before, most of you, but we're a fairly busy, but we're a DGH colorectal unit, operating on about 110 rectal cancers a year. And we've done 37 procedures over the last 3 years. I haven't put all the demographic data on here and all the tumour data, but mainly men, mainly slightly larger gentlemen, people that we thought would be difficult to do open, and they've all gone onto that registry, so our data is part of that data. So if you get your average DGH surgeon and you give them some training, can they get reasonable results? Well, our conversion rate, we've had one abdominal conversion for a patient due to a difficulty making the anastomosis, not doing the dissection. Our leak rate is currently at 13%, which is similar to the registry, slightly lower. We've got a 30-day mortality of 0%. So far we've had one patient with a local recurrence who had fairly nasty disease and no metastatic disease. So we seem to fit in the same sort of group of people. So why are we doing it? What are the potential benefits of it? Well, we've talked a little bit about it in the evidence, but and we talked a little bit about it in the anatomy talk earlier, but it's being able to get closer to that difficult anatomy in the low pelvis, which, however you're doing it from above, whether that be laparoscopic, open or robotic, it is difficult to get views on, although I do accept they are better with the robot. But we're getting very close to that anatomy, and the views you get from the bottom when they're good are really, really good. It allows us to be very accurate with that distal margin, making sure we're getting to the bottom of the TME. I hope that means that we're therefore getting better specimens and better nerve preservation. And some of the studies have shown reduced operative time and reduced conversion rates, certainly. No extraction room, as I said, I feel is a bonus that you get sometimes, but it's not what the technique's about. But the difference in the anastomosis also sits more comfortably with me as opposed to stapling across staple lines, which I know some of us have always felt slightly uncomfortable about. But I was asked to talk about the pitfalls, and I'm sure Nicol did this deliberately to me, but there are pitfalls as well. And a lot of them are to do with the fact that this is a difficult learning curve, and I'll try and show some videos which I hope are going to work. But there can be some issues in terms of your insufflation from below. The anatomy we've talked in detail about, and I won't go back into that again, but that can bring up some interesting complications, including what everybody panics about, which is the urethral injury, but also bleeding. We have to be very careful when monitoring those anastomotic leak rates to make sure they're certainly at least as good as, if not better, than those we're getting with the type of anastomosis we've done previously. And anybody who does Silsra surgery will know what restrictions that gives you as a surgeon, and when you do that transanally, that really doubles, and there is a significant learning curve to this procedure. So hopefully this is going to work. This is looking at insufflation problems. So with a normal insufflator, it blows for 3 seconds, and then it stops for a second and measures, and then it blows for 3 seconds. And if you use your normal laparoscopic insufflator, you get this. You put any suction in, and everything's moving. It's like being a cardiac surgeon. So not easy, okay? So people have thought of various ways to fix this, but this was a very important deal breaker ritually, which is an insufflation device that basically continuously insufflates and gets rid of that problem. And it changed the way everybody was doing a transanal TME pretty much overnight, really. This is courtesy of the guys in Colchester, but we talked a little bit about the anatomy. This is the prostate and urethra, this is the mesorectum, and this is your rectum here. And one of the problems is that if you don't identify that plane early on in your dissection, it's very easy to dissect all around here like we do from above, so that it's at the back, and the specimen starts to lift up because you've got air pushing it forwards, and suddenly you've got this view. And when you get this view, suddenly this looks like your mesorectum up here, okay? And that's where you suddenly start finding that your urethra is right in front of you. And if we can get this to work. Okay, so this is not one of my videos, I'd like to say, although I'm sure I've got some that are equally awful. So here they've done lots of dissection at the back, like we do from above. They're doing lots of lateral dissection, but I hope you can all see there's some twitching going on. Okay? twitching means they're on the sidewall muscles. You shouldn't be getting twitching like that. So they're going around the back, they've not found the prostate yet, they're going around the back, there's some lovely areolar tissue, and they think, oh, this is beautiful, we're in a really lovely plane here, very happy with all that. This is the wrong areolar tissue. This is far, far too lateral. The plane is in here somewhere, okay? But it looks like a plane. You don't get into that plane from above, okay? So they've done all that at the back, they're now pulling the specimen down. They go, gosh, it's quite a big tumour. Quite a big tumour, what's this? Up here. And we'll just, we'll have a little look, and we've got to divide that, because that's got to be, we want to stay out of the rectum. And then suddenly, we start to see the catheter appear. Disaster, okay? So, and the reason for that, the reason for that injury, is because you're not, there are ways to avoid that now in terms of making sure you've identified the prostate at the front before you go anywhere at the back. But early on in the technique, I think a lot of it wasn't recognised.
Dr. Nicol, for the sake of time, I think we have to conclude. So.
Yeah, sure. I will wrap up. I think there's one slide. Is that okay? About 30 seconds. So this is just showing the plane at the back, and again, this is just showing you that it's far too deep here. And in a moment, they'll just make a great big hole in a blood vessel, because they're right. And this is sacrum. This is all the presacral vessels. So again, far too deep in the anatomy that we've shown. Miss off the last one. So finally, the future, randomised controlled trials. We need to know if this really is the way to go. It is difficult, it is challenging, it does have a very steep learning curve. There are new skills to develop, new views to learn, and we need more data. But it may give us another thing in our armamentarium in terms of approaching those difficult rectal cancers. And thanks to lots of people for all the slides and videos.
We have time for one or two questions. Please, on the floor. Yes? Ivano?
I mean, to be honest, I think that there is only one reason for this operation to be done, and this is the difficulty that we have laparoscopically to put a stapler in very low cancer. So my question, I always wonder, what is the indication for this operation? Because if you have a very low cancer, you are going to do an intersphincteric dissection and a coloanal anastomosis, so you have no need to do the stapling of the rectum. If you have a tumor
short question.
If you have a tumor high cap, the question is already implicit, is what is the indication? Because we have the indication for 2 or 3 centimeters tumor, this is the area, and we have a lot of learn from the learning curve. So it's worthwhile to popularize this operation and to spend time training people to do this operation for maybe 10% of the tumor?
So I entirely accept your point. The early adopters have suggested that that it should be wider used. I firmly believe that it's on a very specific group of patients. I agree with you. I think it's on people who have a difficult pelvis, and I think it's on people who've got mid-rectal tumours. So you are going to give them an anastomosis, but probably a very low anastomosis. And those in whom you know that dissection is going to be very difficult from below. And I certainly feel we've had patients that we've managed to do an anastomosis on and managed to complete a good dissection with a really lovely TME on that we'd have been really struggling with if we hadn't gone on transanally. But I agree with you that I think it's a limited number of people, and therefore I think it's something, personally I don't think it's something that's going to be in every centre. I think it's something that you're going to have specific people in high volume centres are going to offer.
Thank you very much. So we got a big organization problem including this in our armamentarium. And Søren, please continue. Thank you very much for your lecture.